Okay, hello and welcome everybody to this webinar this morning on a biomechanical approach to neck pain and how this impacts your treatment. I'm Dominic Smith. I'll be your host this morning. I am the clinical application specialist at PhysiQuip. Just before we get started, a little bit of housekeeping. Just double check and make sure that your microphones are on mute. The session is being recorded, so just to avoid any background noise, just make sure it's on mute. You'll be sent this recording after the session as well, once it's all uploaded. If you do have any questions at any point during the presentation, there is a chat function that you'll find in Zoom at the bottom of the screen. Please post any of your questions in there and we'll try and get them answered. The webinar this morning will be delivered by Natalie. And we'll be split into two sections. We've got a presentation and then we'll have an interactive Q&A session towards the end. But before we get started with all of that, it would be great to know and find out who we have on the session. So if you could please, we're just going to pop up a poll. If you could answer that for us, that will help direct some of the content. We'll just leave that on 10 seconds. If you just answer who you are and then submit that. And then we'll just feed that back to Natalie so we can direct some of the content for you. So if that's all good, we'll just post the results now. Wonderful. So I got a good mix there, Natalie.
Yeah, absolutely. It looks great.
So a very good mix. So MSK therapist, which is great. And we've got a couple of other on there as well. So perfect. So let's get into the actual webinar now. So just a quick introduction to PhysiQuip. So we are a med tech technology company distribution in the UK, and our aim is to work with some of the best technologies and bring that to the UK market. Our education is focused on working with some of the best clinicians from around the world. So that's one of the reasons why I've invited Natalie on to talk on this subject and bring this to you guys and see how it might influence and help with your clinical practice. So with that being said, I'll introduce Natalie Perkins, who is joining us from Sydney, Australia. I'll let her do all the introduction for herself and get cracking on with the presentation.
Excellent. Thanks very much, Dom. And hello, everybody. Thanks very much for inviting me too, Dom, to do this. I am a physiotherapist in Sydney, Australia, as Dom said, with nearly 30 years of clinical experience, which started predominantly in professional elite sport. And I got to travel a lot with professional elite sports people, and then somewhere along the way I became really interested in developing, I guess, a clinical reasoning and treatment model that made more sense of what I'd learned at university. And in that became particularly interested in the management of complex and chronic spine pain, lower back pain and neck pain, because I think we find that they're the most common things that we need to treat, and arguably the most difficult things, I think, largely because it's very difficult to come up with a definitive diagnosis in medical terms. So what I'd like to do today is to go through a very simple model that I've created over the last 3 decades, and it's really tonight deliberately simple. The reason being that over the years I had a lot of patients come in, they'd been told all sorts of stuff by various therapists, but they never really understood what it was that was wrong with them. And rightly or wrongly, I've created an educational platform that helps them to actually understand what might be going on in their neck, and helps them understand, I guess, the background as to why we might be treating the way we're treating, and particularly why we might be asking them to do behavioural changes such as postural change or exercises. I think that particularly when it comes to exercises, it's pretty normal for people to not be particularly motivated to do exercises once the acute pain's gone. And if you don't have a reason why, it's even less motivating. So hopefully I can share with you tonight some thoughts that you might be able to take straight into the clinic tomorrow or today. It's my tonight, your today. Even this afternoon you can start using them, just to help you explain better to your patients essentially a biomechanical approach to neck pain. Now, a bit like I rarely treat a lower back without also treating the pelvis. I rarely treat a neck without also looking at the shoulder. So the neck shoulder is a very tight unit. So as you'd all be aware, you know, your C5 giving a nerve route to most of the shoulder muscles, it's pretty hard to dissociate the neck from the shoulder and vice versa. So we're going to touch on a little bit of both because I think they both relate to each other very closely. Now, those of you who are physios, you are probably, if there's a very heavy Maitland approach, which I believe there is in the UK, there certainly is in Australia. Apologies to the chiropractors, but Maitland's not one of your guys, but I think the same teaching is much the same, is that we were very much taught that a lot of cervical issues and spine issues in general were related to joints. Now, I'm not for a second disputing that. I think it's very difficult to separate any piece of anatomy when it comes to the body, and humans are very complex. But for the sake of this evening's presentation, I'd just like you to shift your thinking a little bit to consider more the muscles. In the Maitland approach, as a summary, we palpate down or feel down the cervical spine, and we're feeling for areas that offer resistance. And then in technical terms, don't know how it's taught where you are, but we were originally taught 3 lots of 30 seconds of treatment and then reassess the patient. And when I came out of uni, I went, well, 3 lots of 30 seconds, why do we treat for 90 seconds anyway? Surely it makes sense that if you feel resistance, you treat until the resistance changes. If we know that strength and, pain and range of motion correlate with that resistance that we're palpating, why would we expect pain or range of motion to change unless the resistance has changed? So that was the first problem I had. The second problem was that I was very much taught that it was about the joint. And I went, well, what's actually changing in a joint? How can a joint actually be restricted? And when you think of the anatomy of the joint, you can't change a capsule in 90 seconds. It's not like you've got increased viscosity of the fluid within the joint space that's going to suddenly change because you've frictioned the surfaces together for 90 seconds. So fundamentally, I thought, well, anatomically, the only thing that actually has the capacity to change its physical characteristics within 90 seconds are muscles. You know, they have the capacity to turn on and off instantaneously. So I started back then to shift my thinking towards, well, what if we consider more of a muscular approach? Range of motion, movement, is caused by muscle. So if something hurts when I move it, could it not possibly be the muscle that is actually the cause of the problem? So tonight we're really going to focus on the muscular potential to neck pain, headaches and migraines, and to really look at how treatment of those things can actually alleviate those symptoms. And one good thing to think is that, you know, when you fracture a neck, and unfortunately I look after a bunch called Nitro Circus, and they flip motorcycles and all sorts of other things in the air. So unfortunately they frequently land on their heads when they don't land on their apparatus. So I have actually had the misfortune to be front and center with a cervical fracture. It was really interesting because the patient reported very minimal pain at the time. But as we know from the Canadian C-spine rule, there was very, very limited range of motion. He couldn't turn his head in either direction. So straight away he was put into a stabilisation and shipped off to hospital. And thankfully it was a stable fracture and there were no complications. But if you think about the level of muscle spasm that occurs when exposed to a significant trauma, that shows you how protective muscle spasm can be and that it's an innate function. So I think a lot of what we see in the clinic is potentially a dampened down version of that protective muscle spasm as well as potential overload. So that's what we're going to have a look at. Now, one of the things that we commonly talk about is posture. And I certainly have had many patients present to the clinic saying, oh, I know my posture's bad, and there's this silent, but surely that can't be why I'm in pain. Well, from my perspective, posture is a huge component of why potentially somebody might be in pain. And again, I'm not quite sure what's happening in the culture in the UK, but certainly I'm starting to hear rumours out here as a result of Peter O'Sullivan releasing a paper that determined that a regular change in movement, and that therefore movement was more important than correct posture, and that this holy grail of finding perfect posture was actually a sham. Now, as a result, I have students come into my clinic for their clinical placement saying their previous supervisor has said that slumped posture is absolutely fine and you can slump and it doesn't matter. Now, I'm not disputing the fact that regular movement is probably much, much better than any prolonged position. However, in a society where we are, by our cultural constraints, tending to need to have sustained postures, particularly those in sitting, suddenly posture does in fact become more important. But what I find is that when we talk about posture, very few people, including clinicians, have a particularly good understanding, or maybe not an understanding, but they have a poor description to their patients. So patients know this word posture, but they don't really know what it means. So if we look at what I think posture is and why I do believe personally that there is such a thing as perfect posture, it comes down to the laws of physics and the anatomy of the spine. So when you look at the spine, you will know that there are 24 vertebrae. There are 7 vertebrae in the cervical spine, 12 in the thoracic, 5 in the lumbar spine. Now, we also know that there is a lordotic curve in both the cervical and the lumbar area, and a kyphotic curve in the thoracic. Now, one day when I was bored, I suddenly went, the maths of the spine, I'm sure, is not a coincidence. When you add 7 and 5 together, both in a lordotic curve, you get 12, which happens to be exactly the number of vertebrae that are in the thoracic spine. So I started to wonder whether if you added those two together, you got a straight line, which is the line of gravity. So in essence, a perfect posture could potentially be that where all of the curves are in the right place and the summation of those curves equals 0. So I took that concept to an orthopedic surgeon, spine surgeon, and suggested that that might be a relevant thing to look at, certainly when they're talking about putting in cages, if they're doing open reduction, internal fixation, that sort of stuff, taking out a vertebra to shove in because there's a tumour and put in a cage that is supposed to represent that vertebra, that the height of the cage might actually be relevant. And he raised his eyebrows and he kind of thought it was a bit funny. And then he pulled up a fancy software and he said, well, let's have a look. And he chose a random MRI and he measured the height of the cervical spine and the lumbar spine, added them together. And it came out to within 0.02 of a millimetre of the height of the thoracic spine. He did that 5 times. So he and I are both convinced that it is not a coincidence at all, that there is something in the design of the spine that actually enables all of those curves, and the height of the vertebra in the cervical spine plus the height of the vertebra in the lumbar spine pretty much approximates the height of the vertebra collectively in the thoracic spine. So perfect posture is about making that happen. So we are actually perfectly aligned against gravity. So speaking of gravity, we know that gravity, well, this slide says pushes down. I think we all know it pulls down. So if we think of the spine being a series of hard vertebrae, like concrete blocks, which they are, and this is, as I said, very simple language because this is how I explain it to patients. You get these hard blocks of vertebra and interspersed with squishy intervertebral discs. And I talk about the discs being like balloons filled with jelly. So you've got a hard bit, squishy bit, hard bit, squishy bit in a column 24 units high. And if you apply a compressive force to that system, the whole thing's going to concertina down like a giant spring. And indeed, that's exactly how the spine is designed to function. It's incredibly clever, and anybody who says we shouldn't have got up off 4 limbs is missing the point completely. So that's all well and good as long as the spine is straight. And when I'm talking straight, I'm talking the summation of the curves as we know them anatomically equaling 0. However, in our society, we don't often see that. Now, of course, as soon as you fall forwards or backwards, but particularly forwards of gravity, suddenly you are needing something to hold you up. The further forward you are, the greater the moment arm, and therefore the stronger the forces that are going to require to pull that system back up again. Now, so when you think about it, muscles are intrinsic guy ropes. So when posture is not aligned correctly against gravity, we're making muscles work. The further forward the head is protracted, the more significant the torque is going to be, and therefore the more significant the muscle activity is going to be. I would argue that As a result, a lot of patients get diagnosed with having weak or neck or back muscles when in fact they've arguably got overloaded muscles. If a muscle is constantly active because the person has their posture anterior to gravity, then the muscle constantly being active can't possibly get weak. Do we know that isotonic isometric strengthening programs work? Well, they don't not work. You certainly couldn't get weak from that. But the problem is that if a muscle is already in a state of contraction at relative rest, it's got not terribly much to offer when you ask it to, say, straighten up and pull the person back into an erect posture. So those patients that when you say, look, I want you to sit straight, go, oh no, that hurts. Oh, that's really hard work. I'm much better when I collapse like this. It's really because those muscles that are already overactive, you're asking to work even harder. Hence, we get this, I think, miscommunication of thinking that the muscles are weak, whereas in actual fact, they're not, they're overloaded. Now, the cross-sectional area of the rectus spinae running up and down the vertebra is going to be far too small to be able to support the mass of the head in a forward position. It's going to be, quite heavy. We actually use a bowling ball we've mounted on a stick at work. And for those patients that don't necessarily understand the physics that I'm talking about, even though I draw these very simple little drawings, we get them to hang on to the bowling ball and start to tilt it forwards. So I'm sure you've all had patients who've had a protracted head posture of, 30 degrees or more. If you hold a bowling ball on a stick at 30 degrees, you'll feel how much harder your arms have to work to hold that system up. So it gives a really good idea of how much harder the neck and shoulder muscles have to work to hold on to the head. And most patients, when we put that in their hands, really get a really good understanding of what it is that makes good posture and why their posture is contributing to their neck pain. So I'd encourage you all to go out and get a bowling ball and whack it onto a stick. Okay, so as I mentioned, because the cross-sectional area of the erector spinae is too small to support the head with an increased moment arm, we have to recruit the shoulder muscles. Principally, we're looking at recruiting levator scapulae and the upper trapezius, which people will always say is tight. So when patients say to me, oh, I carry all my stress in my shoulders, I usually say to them, well, just pull your head in. And I'll say, you'll still be stressed, but you won't be in pain. And the pull your head in catchphrase usually gets a laugh or two, and they actually remember it quite well. I encourage them to ask their friends, co-workers, family to also use the catchphrase whenever they see them throwing their head in a protracted position, and they're amazed at how supportive those people can be at telling them to pull their head in. I do encourage it to be in an anatomical sense, but I think it's used for a variety of other reasons as well. Okay, so now we've recruited the upper traps and levator scapulae. If we take a quick look at the shoulder joint, we'll remember that it is the joint is in line with the plane of gravity, so it's an inherently unstable joint, with our ball and socket being not much of a ball and not much of a socket. As a result, we need to have our rotator cuff to stabilize. If we're recruiting the upper trapezius and levator scapulae, in essence, to hold the head on, one would argue that those muscles are primarily part-time workers that are designed to activate the scapula and essentially at the end of the scapular complex to put the hand in an exotic place. So we have recruited a part-time muscle and given it a full-time job holding the head on. And then if our client goes and hangs the washing on the line, or goes driving a car, or using a mouse, or basically uses their arm for any reason whatsoever, we've taken a part-time worker, given it a full-time job plus overtime for part-time pay. Now, most workers might suffer that sort of condition for a short period of time because they're team players, but after a long time, they'll get pretty disgruntled, which is what happens to the muscles of the shoulder and neck. If we go back to the shoulder joint, knowing that it is inherently unstable, those rotator cuff muscles are very important for stabilizing it. The shoulder girdle is in essence a passive system. Yes, there is some degree of EMG activity that holds it on, but if you think about it, there's a weight of the scapula that sits on the posterior aspect of the thoracic cage, and then the shoulder girdle rests a bit like a saddle on the thoracic cage, and pectoralis minor pins it down at the front, so tethers it at the front. So we've got a relatively passive system of our shoulder girdle resting on our thoracic cage. So when you flex the thoracic cage forward, the shoulder girdle protracts forward and you get a passive internal rotation of the humerus at the same time. Now, from a clarity for patients, I describe it very much like a simple tent. So your tent post is the glenohumeral joint, and the 4 guy ropes of the old-fashioned tent represent the 4 main structures of the rotator cuff muscles. Now, as you would know, if you have a change in the length or the tension of any of the guy ropes of the tent, you're going to automatically change the length and tension in all the guy ropes, and your tent is not going to function particularly well. So if we put that in perspective of the shoulder girdle, if we flex the thoracic cage and the shoulder girdle protracts forward, we get that passive internal rotation of the humerus. We are causing elongation of the posterior structures, your infraspinatus, your teres minor. We are causing shortening of the anterior structures, particularly your pec minor. And if you think about it, you completely change the line of pull of supraspinatus, which in the correct posture with a more extended thoracic spine, supraspinatus will pull in pure plane abduction. As soon as you protract the shoulder girdle, you are getting some degree of anterior plane or frontal plane, where you're getting the supraspinatus pulling forward slightly. So I explain to patients, it's a little bit like pulling a box on a rope straight ahead versus a box on a rope round a table leg. So little wonder we get tearing and tendinitis of supraspinatus when it's not pulling in the pure plane of abduction. But most importantly, what we've done is alter the length-tension relationship. Now, again, not sure about your training and your understanding and your memory of length-tension relationship. I notice we have a few students. So take note, students. I believe this to be one of the most important physiological principles, that the length-tension relationship relates to the maximum number of actin and myosin fibers that engage to create power. If a muscle is overly elongated, there is a significant number of actin and myosin that are unable to connect with each other, so you get a reduction in power. Similarly, if a muscle is overly shortened, you get overlapping of the actin and myosin and they cannot create a bond. So the optimum power output is where the optimum number of fibers of actin and myosin are in connection. Now, to put that in perspective for your patients, when you're describing what happens to the shortening in the front of the shoulder, the elongation in the back of the shoulder, is I talk about it being like a tug of war. You've got 10 men on the opposite team, or women, 10 men on your team. For the most part, they are matched weight for weight, size for size, power for power. But if your 10 men, half of them are holding the rope at arm's length, and the other half are holding the rope at their chest, hopefully you can appreciate that there's going to be a significant variance in the power that they can develop. And obviously they're going to lose the match. So when you're thinking about length-tension relationship, any muscle that is overly elongated or overly shortened can't develop as much power. And therefore it has to work much, much harder to achieve the same activity. So now we're creating a discussion of systematic overload. The upper trapezius is working hard to hold a protracted head on. The levator scapulae is overworking. We're getting all of the rotator cuff muscles in a compromised position. And basically the whole neck shoulder area is getting distressed from basic inefficiency of muscle function related to posture. Okay. So if we take a look at our common seated postures, we can see that a lot of people spend a lot of time in that flexed forward position with a significant talk around the thoracic spine, an overloading of all those muscles, and we can start to see why we might be getting some distress in the cervical muscles. Now, I'd like to draw your attention quickly to the image where you see that is supposedly the correct ergonomic posture, with the knees at 90 degrees and everything looking very neat and tidy. Now, one of the problems with correct posture in sitting is that the correct posture of the spine starts at its base, as is normal for any anatomical or indeed architectural structure. Now, as you raise the knees up towards the chest, you get a rotation of the pelvis as the posterior hip muscles tighten up. So the higher the knees are relative to the hip, the flatter the lumbar spine is going to be. So if you have your client sitting with their legs parallel to the floor, which is certainly the most common ergonomic recommendation here in Australia, I don't know if you're more wise in the UK, it's very, very difficult to maintain a normal lumbar lordosis. And if you don't have a normal lumbar lordosis, and in fact the lordosis is flattened out, it's very, very hard work to then try and get everything else stacked above it in a vertical plane. By dropping the knees below the level of the hips and encouraging an anterior rotation of the pelvis, you're automatically going to facilitate a anterior rotation and therefore lordosis happening in the lumbar spine, which is automatically going to make it easier to somewhat extend the thoracic spine and retract the head. So the next image you can see is not popular, not particularly conventional, but certainly much easier to sustain. Which leads us to the recommendation for standing workstations. If people stood the way they sit at a desk, their centre of gravity would be far too far forward and they would actually fall over. So standing workstations are automatically a better option because you have to align your centre of gravity over your base of support much better to stay upright. However, it doesn't automatically mean that you're going to have better posture and you're going to reduce your pain. All it means is you might compensate more by increasing your lumbar lordosis and just end up with back pain instead of neck pain. So fundamentally, I'm a fan of standing workstations because I think you're much more likely to succeed than in sitting. But I'm even more of a fan of transitioning between the standing workstation and this image, which is a high stool, so that you both get to sit and stand intermittently throughout the day. If you have ergonomic specialists or patients that say, oh, but you know, somebody assessed my workstation and they did it all perfectly and they set up my backrest just perfectly and all of that sort of stuff, as soon as they mention the word backrest, I have concerns. Because whilst there is some debate about the concept of core stability being important for lumbar spine pain, I think it's kind of obvious that it should be part of the stabilisation system of the lumbar spine perfectly. Therefore, having a backrest, which is actually an abdominal muscle rest, but that's much longer than backrest, is actually negating the need for the abdominal muscles to fire. When you think about it, we've been sitting with that backrest or that abdominal rest since the age of 5, when we first went to school 5 days a week, 7 hours a day for the next 13 years. So little wonder most of us don't have that deep core stability because we haven't had to use it pretty much since, well, not birth, but the first 5 years afterwards. Okay, so I do personally believe that core stability is important and that it is inherently lacking in our seated society. So by encouraging a patient to use a backrest, you're actually facilitating the very process that you're actually trying to eliminate. Okay, so my tips for workstation setup, and it is important given that so many of our clients sit so much, you're never going to cure a back or a neck, in my belief, unless you address their sitting posture. You've got to have the knees below the level of the hips, and you've got to train the patient essentially away from using a backrest so that they learn to hold themselves up. I'm a big fan of Neanderthal Man, and I don't believe that Neanderthal Man wandered around the earth looking for a rock with a backrest. He squatted. And when he squatted, he had to hold his own body together. And in essence, I think Neanderthal man was considerably stronger than modern man. Right. So if we start to look more specifically at the muscles that are likely to cause neck pain, you'll be reminded that your levator scapulae inserts into the top edge of the scapula and then into the transverse processes of C1 to 4. It can often be the source of neck pain because its insertion is in the vicinity of the exiting nerve roots, the posterior ramus, and that if you are protracting your head and therefore causing stress and strain on that levator scapulae, you're actually, when we're looking at levator scapulae, it inserts into the superior border of the scapula and extends into the transverse processes of C1 to 4 and can often be, as a result the source of neck pain because it pulls on those transverse processes. And we know that there's the exiting cervical ramus nerve roots coming out from there that form the basis of the occipital nerves that are coming up the back of the skull, and a very common cause of headaches in particular. And if we're protracting the head, we're stressing and overloading that levator scapulae, so it's going to tend to pull on its insertions. You're also going to get point tenderness as the tendons of the levator scapulae insert into the Sharpie's fibers of the periosteum of the transverse processes. You know that the periosteum is highly sensitive, so patients will say, oh, when I touch here it really hurts. They're not necessarily mobilizing joints, they're touching painful periosteum and taut muscle for the most part. So when it comes to treating that area, for many years I did a lot of soft tissue massage, and for a lot of the time it was very painful for the patient, but the releases were excellent and their symptoms disappeared. I then got introduced slightly more recently to the LymphaTouch negative pressure system, which you can see here, which essentially in my belief does exactly the same thing as soft tissue massage, just in the reverse direction. So we're getting stimulation of the mechanoreceptors, we're getting improvement of lymphatic flow, goodness knows what other magical things that it does, because I really don't think we truly yet grasp the value of manual therapy and what happens when you do things to muscles, and in particular the neural story that we get between the connection between the muscles and the brain. But having introduced the LymphaTouch, I can get a very similar effect as the soft tissue massage without the pain. There are certainly some times where I'll start with LymphaTouch to desensitize the area and loosen the superficial muscle, then I might switch to thumbs. But in any case, all of it is about reducing the pain for the patient predominantly while still getting an excellent result. And it certainly has saved my hands in terms of wear and tear on my thumbs. So I'll release the posterior shoulder muscles, I'll release the thoracic erector spinae, and obviously I'll release the upper trapezius and levator scapulae muscles, all of which are going to feed into the cervical spine and might be contributing to why our patient has neck pain. That's just an image there of the thoracic spine work that I'll do, keeping in mind that you've got multiple layers of erector spinae there to get through, all of which are going to be overloaded with your patient in that thoracic kyphotic posture. Point of note though, today I was treating a patient, a new patient, and she's a personal trainer, and as she was sitting there I was looking at her posture, and in my notes as we're chatting away I wrote good posture. When I assessed her, however, I realized that her thoracic spine was completely rigid. It was stuck in neutral. So I call that functional kyphosis, that they actually function like they have a kyphosis because they're unable to extend actually or flex. And I was able to predict to her that she was also getting lower back pain that she didn't know that she had, because she was basically using her lower back as a complete hinge because her thoracic spine was doing nothing. She'd had something like 9 years of neck and shoulder pain that we were able to fix in one session, and she was quite excited by that. And it was simply exactly what I'm telling you here today, addressing the underlying postural issues, the immobility of the thoracic spine, the protraction of the head, and releasing all of these muscles that were overworked and underpaid for a very long period of time. I also had a patient who had developed migraines from the age of 15. She was advised that they were hormonal because they came on when she started menstruating, and she was advised that they would subside when she went through menopause. She is now in fact 65, has been through menopause a number of years ago and was still getting daily migraines. With 2 treatments we managed to get rid of the migraines. She was off all medication. She hadn't taken any form of medication in over a week when I saw her this morning, and she thought it was a raging success. This poor lady had been poked and prodded and injected with Botox and fed multiple different pharmaceuticals, not all of which were beneficial to her, over that period between the age of 15 to 65. And unfortunately, it was a simple cervical spine and postural treatment that was necessary to alleviate all of her symptoms, which was very nice for me to have that slight hero moment, but to be honest, I was actually bitterly disappointed in the medical system that led her in agony like that for as many years as she did. I also today had a case of a lady who had degenerative disc disease in the neck, but again, it was very clear to me that she was jammed up in the upper cervical area. She was jammed in the lower cervicothoracic junction area, and not surprisingly, she was wearing out the facet joints and the discs in the mid-cervical region because they were the only places she was moving. I told her that, you know, if you put a car in a vacuum sealed garage for 50 years, nothing wears out, and the things that wear out the fastest are the things that move the most, aka the tires. So degenerative disease, as I see it, is predominantly about load, and that if you're getting one area that is loaded in preference to other areas, you'll see that wear out faster. So when you get an x-ray, I encourage you to look at that and go, well, not just the bits that are the problem, but look at the other bits above and below on the x-ray, and if they look pristine and beautiful, then there's probably your problem because they're not absorbing any load whatsoever, which is why they're not degenerating. Okay, if we have another look at the deeper neck muscles then, to remind you, you'll recall that semispinalis capitis lies underneath the upper trapezius and over the top of the suboccipital muscles, and our greater occipital nerve pierces through the semispinalis capitis. Again, probably not telling you something you don't already know, but that greater occipital nerve is deemed to be one of the most common causes for headaches, certainly up the back of the head. You can also get, with the symptoms of neuralgia, a continuous aching or burning that happens in the head. There might be intermittent shocking or shooting pain, patients will describe, that generally starts at the base of the head and goes to the scalp on the unilateral side that might be distressed the most. Patients will often report a pain behind the eye, and you've got to remember that this nerve starts from the C2 posterior ramus, which we said you're already getting some attachments of your levator scapulae in there, as well as some of the deep muscles that we're going to have a look at now, which are your suboccipital muscles. Now, I love the suboccipital muscles. I think they're an often forgotten bunch of muscles that we generally say, oh yeah, that's suboccipital area, but we've forgotten what all of their names are. Rectus capitis posterior major is a muscle that is not only very valuable for extending the head, but is super important for, it's an anticipatory muscle that as the eyes raise up towards the ceiling, rectus capitis posterior will fire to basically extend the skull in conjunction with the eyes. Now, I also do a lot of work on concussion, and it's one of the problems that you can get symptoms in patients when there's this mismatch between what the eyes are doing and what the skull is doing. And often I'll sort that out by just doing the LymphaTouch on the upper part of the posterior neck, so that we're capturing that rectus capitis posterior region and just reducing the tension through there, and it has an amazing effect on their capacity to see clearly, to track objects, to not feel nauseated when they're looking particularly up. The same thing happens with your obliquus capitis, and that's anticipatory for the horizontal movement of the eyes. So it will actually anticipates to rotate the head when the eyes start to turn in the horizontal plane. So both of those muscles are super important in terms of concussion, and also those patients that you find will say that they're getting a headache with nausea in particular, and there's that mismatch between the eye, the middle ear, and the cervical spine. So those muscles are a couple of little favorites of mine in terms of focusing treatment on them. Sometimes it is necessary to get into the thumbs, in with the thumbs, so that you're really down very specifically on your rectus capitis, and that you get onto it and release it completely. And that's probably one of the things that I would say is poorly done with students and practitioners that I mentor, is their lack of capacity to completely release the muscle. You know, they do a bit of something and it's a bit better, but they haven't actually got that complete release. So as a clinician, I really encourage you to trust your feel, to do that palpation, feel that restriction, and not give up until you actually get a complete release of those muscles. Now, from a chiropractic perspective, I have great admiration for any chiropractor who can get a C01 manipulation. I believe it's very difficult. The same with a C67, C7T1. The main thing being that you've got that mid-cervical area that's very, very mobile, and you have a great big immobile skull that's very heavy, and then you'll see one too that are very stuck. So to be able to wind up to get a specific manip in the upper cervical area, I think takes a lot of talent. I know there are other techniques that can be used at that atlanto-occipital joint that I'm not familiar with from a chiropractic perspective, but again, those of you who know how to use those treatments, consider using them more significantly when you're dealing with any of these headaches in relation to trying to get that release of those suboccipital muscles. So when I'm using the LymphaTouch, I'll switch to there's a very cute little suction cup that we put on the apparatus that is perfect for getting into those tiny little muscles up at the top of the neck and through the erector spina of the neck. And as I said, most patients report that it's much more comfortable having the negative pressure than my thumbs digging into their muscles, even though the end result is much the same. So if we have a quick revision of those nerves that are related to that area, you can be reminded, as I mentioned before, of those occipital nerves that cause the headaches up the back of the skull, mostly coming off the posterior ramus of C1 through C3, where there is a lot of muscle insertion of those suboccipital muscles, your levator scapulae muscles, and your deep erector spinae muscles. Okay, and to put that into perspective more anatomically, you can see there's a nice vision there of the piercing of the greater occipital nerve, remembering that all of that's sitting underneath the very taut upper trapezius muscle that's also putting pressure on all of that. Now, when I have patients come into the clinic with neck pain, a lot of times they get confused that I haven't really done anything. So very quickly, to put things in perspective so that you can help them understand why they might be getting their issue, I break all stories that patients come in with down to, is it damage or dysfunction? So a damage story will be a single moment in time where there is immediate pain, and usually there is a very defined, describable external force. The pain is usually significant enough to stop them from doing whatever they're doing and go, ow. The force event is usually quite significant because it needs to justify the destruction of perfectly wonderful tissue, so the tearing of a muscle or a ligament or a fracture of a bone. And we know that damage heals with time. So after the first 48 hours, there should be a slow but steady improvement over the course of time. Most of what I see, though, is not that. I would call it end-stage dysfunction. There's no real event that it's insidious onset or they just woke up with it, or commonly they'll reflect and find the most exotic physical activity that they've done in the last 2 weeks and blame it on that and say, oh, it was that gym workout I did 2 weeks ago that I must have pulled something down. So if they don't have a defined event, then I already dismiss it as likely being end-stage dysfunction. The onset of pain is gradual, or it might be sudden, but from a relatively minor event. the force of the event is not significant enough to justify damage to perfectly wonderful tissue, and it certainly doesn't get better over time. And I liken it to, you know, a heart attack or a toothache, that you don't leave them in the hope that they're going to get better. And similarly, I don't think when patients have gone for a run and had a heart attack, anybody's blamed it a sports injury. So we know that the load was the catalyst for the heart to fail. Similarly, a small event can be just an increased load that might cause muscles of the neck to fail. Which leads us nicely to whiplash. Now, very quickly, some of the major research findings are that we know that there are very few accidents that result in significant changes on MRI or X-ray. We do know that, according to the statistics, that the speed of impact is not a great prognostic indicator for the severity or duration of a whiplash, and we do know that women tend to suffer more than men when it comes to whiplash. So if we have a quick look at the mechanism of whiplash, which I'm sure you're all familiar with, you get a reduction in the cervical lordosis temporarily, where you can get a compression of the cervicothoracic junction, so you see sort of 6 to T2 can get compressed significantly before you then get this massive whip and extension of the skull and potentially damage to the upper cervical spine. Obviously, the next frame can be where everything goes forwards, and so now we're getting these posterior structures that are trying desperately to stop the head from flying through the windscreen, pulling back and being essentially overloaded. So it's little wonder that we end up with quite a lot of distress in the posterior muscles of the neck during a whiplash. But one of the other important things to keep in mind is that you've also got the vertebral artery and the posterior root of the first cervical nerve sitting just underneath the occiput. So as the skull tends to go backwards in that whiplash system, you can get compression of those two anatomical structures that can also significantly contribute to why people get their symptoms. But something that might be new to you is the discovery of what's called the myodural bridge. And this is connective tissue that essentially runs between rectus capitis posterior minor, so one of those suboccipital muscles, and the dorsal spinal dura at the atlanto-occipital junction. And these fibres, these connective tissue fibres that we're calling the myodural bridge, are thought to provide an anterior anchor to stabilise the dura mater from the anterior translation during flexion. So when you think about flexing forward, you could essentially concertina down your spinal cord if there wasn't something holding the spine back and allowing it to go over a curve rather than to create a sharp bend. Any of you using fibre optic cables know that you can't squish the cable down because then it doesn't work and the whole thing's worthless. I think your spinal cord is much the same. So I think it's really interesting, and this is a relatively new discovery. There's a paper by Sun et al. That was earlier this year, before the world locked down all sorts of everything, and it proposed that we actually give this collection of connective tissue a ligament name, and that it is potentially really important because it attaches to the dura. So those patients who've had a whiplash, that you have these unexplained well, total body pain, you know, hamstring, sciatic pain when I got a whiplash, all these headaches when I got a whiplash. It's potentially the torsion that's placed through that myodural bridge that's then pulling on the dura and creating irritation in that whole system. Very quickly, so that we've got time to answer some questions, I will also remind you of the anterior neck muscles that don't often get a lot of love, but if you think about them anatomically, they also attach onto those transverse processes. I do a lot of treatment of anterior neck muscles. I'll get into platysmus, I'll get into the scalenes, I'll get into myohyoid and all the hyoid bones at the front, because releasing them has an amazing effect on the balance between the anterior and posterior systems. Obviously, your sternocleidomastoid is a huge one when we're talking about neck pain and headaches. And if you're familiar with the work of Gwen Joel et al., she's done a lot of work in showing that the strength of the deep cervical flexors is a significant cause of headache and neck pain, and that there's often an overactivity of the sternocleidomastoid to try and make up for the fact that those deep cervical muscles aren't working. If you go back to the postural story, most people, when they protract their head, tend to lift the chin up and they elongate all of these anterior muscles. If you tie that in with your length tension relationship, you're getting a reduction in power as a result of the length tension relationship being destroyed. So posture to me is the key in restoring a lot of strength issues, and a lot of people can be misdiagnosed with strength problems that they arguably don't actually have. Okay, I hope that has fast-tracked you to some points that you can share with patients, and hit me up with some questions.
Perfect. Thanks very much, Natalie, for that. So I'm just going to get straight into some questions. We've got 10 minutes left. Got a few questions that were pre-submitted and also that have come in. So the first one is from Eileen Stringer. She's referring back to when you were talking about the menopause and neck pain as well. Is it common for women who have gone through the menopause to have a spontaneous C5 collapse with impingement syndrome?
Oh, I wouldn't say it's common, because I don't know that I've ever seen that in 30 years. I think when it comes to hormonal things and migraines and things like that, I think the body's really complicated. I'm not for a second suggesting that all migraines can be fixed by, you know, putting your thumbs in the suboccipital muscles. But I do think that there is a lack of understanding of this concept of overload. So I think that the menopause possibly creates a chemical disruption, and that certainly my experience there is that hormones tend to heighten pain responses. So not that it caused something, but the patient is now suddenly aware of it because of the hormonal shift. We also get a reduction in, you know, potentially calcium uptake that can then cause the bone to be more osteopenic. And so if you're getting an area, say, of C5 overload, which is very, very common, given that you get stiffness in the upper thoracic spine, that cervicothoracic junction, that tends to get a bit kyphotic. Your next available vertebra is the C5 that tends to then overextend and absorb an awful lot of force. You have a degree of osteopenia with menopause, and I could totally understand how there's going to be far too much load for the vertebra. I hope that answers the question.
I hope so too. And I think leading into that as well, Fatima asked what could be the reason of headache in women with near menopause, and then what should be the treatment, or what's like your ideal treatment for that?
Well, I think probably one of the things that they found in that research paper by Sun when they were looking at the myodural bridge, which was really interesting, was that men have a much thicker myodural bridge than women. So if we tie that into the whiplash story, then that might explain why women have more symptoms than men do. If we relate it to poor posture, it's possible that the same thing is happening. I think we probably all know that women are smarter and therefore have heavier brains. So I'm kidding there. I think the menopause story, that hormonal story, is a difficult one to succinctly sort of tie down to just one thing. I think there are multiple factors, and as a clinician, I think you need to be looking at multiple areas. Is this partly a chemical pain, chemical hormonal? Is it postural? Is it strength related? I think when it comes to headaches and migraine, there's usually a multifaceted approach that's required. But what we hopefully looked at today was a sort of a starting place for you to then get some degree of trust with your patient, because you're alleviating their symptoms, and then you can start to layer on all of the other things that come into play.
Perfect. Hope that answers your question, Fatima, on that. Ken Ross has asked about how you mentioned that forward head, how the forward head pain is the driver for most neck pain. The forward head position, sorry, is the driver for most neck pain. How would you treat the anterior musculature, which you actually kind of went on to just literally just after you asked that, but how would you treat that anterior musculature of the neck alongside the posterior, and do you do the both in the same treatment?
Yeah, I do. Like I do a lot of work with patients in supine, basically, and really just do soft tissue work all the way under here. Like I just rely on my hands a lot. I'll use the LymphaTouch. I love the LymphaTouch for sternocleidomastoid. You can be really quite specific on it with the little, the cute little head. But, you know, I say to patients, it's the worst facial they ever get. You know, I come in, as I said, under platysma and working up into the temporomandibular joint, you'll often find a lot of connection between the TMJ and C2, temporalis as well. So basically, I just kind of release pretty much everything. And I do find that when you do all of that, I have great success. And that's all I can say. Maybe I attract the patients that need this type of treatment. I don't dispute that, but I'm a huge believer in muscles being a significant cause of just about every pain that everybody has when we're talking neck pain.
Yeah. I suppose actually coming into like sort of with the treatment and things as well, and we know one of the sort of more controversial questions around neck pain is, do you use stretches as part of your treatment program?
No. Largely because, again, if you think about that length tension relationship and a lot of, you know, even in our Motor Accidents Authority here releases a document to help patients self-treat after a motor vehicle accident, and one of the exercises is, you know, stretching of the upper trapezius muscle. Now, hopefully, with what we've done tonight, we've explored the concept that the upper trapezius is not short, it's overloaded. So if I wandered around with my leg like this, then yes, you'd get an adaptive tightening of the upper trapezius muscle and it would be appropriate to stretch it. However, we're not. We're talking about an active contraction. And I think there's a lot of misconception between what's an active tightening and what's a passive tightening. And unfortunately, we use the same language. We use the term contracted. We use the term tight. Far too many physios, and I don't know about everybody else, as soon as you say the word tight, they stretch it. It's no different from glutes. How can gluteal muscles possibly be tight in a population that spends most of its life sitting? You know, for the muscle to be adaptively shortened, it needs to be in a shortened position, which means your leg has to be behind you, extended for a long period of time. So the same is true of upper traps. So for me, adding a stretch to a muscle that is already overloaded and arguably annoyed, you actually run the risk of reefing it off the insertion and making the whole situation worse. So I'm a fan of offloading muscle that has been overactive. You might need to stretch the very top, the short muscles at the top of the neck if people have protracted and then extended their neck. So I might go into a retraction and extension stretch that way, or an N=1 Mackenzie retraction. But yeah, I'm not a huge fan of stretching the neck muscles because I just don't find it to be effective, and frequently it's provocative.
Yeah. And you should mention about the loading as well. So obviously you're trying to find an optimal amount of load, you know, looking at, trying to find that sweet spot of how much load they can manage. I suppose double barrel question, which is better, or which do you find is better? Is it a mixture, isometric, eccentric, concentrics? Is it a mixture of those? And then also, how do you actually determine what is the right amount of load for that patient when you're doing the rehab with them?
Well, when it comes to neck strength, which I mean certainly super important, I think when we're talking something like whiplash, one of the problems is that you know, I look at the data from whiplash, and I've done a lot of this sort of stuff, and there's a lot of confusion in the area because we're not seeing these cause and effect sort of really delineated things that we think we should see. It would make logical sense by the laws of physics that the harder you hit, the more damage should be done, and therefore the worse you're going to be. And we're not seeing that. But then I put it into perspective of, okay, well, if I was going to get neck pain on Thursday, just from bad posture and sitting around and, you know, weakness and et cetera, and I have a car accident on Tuesday, that's like going for the run when I was already going to have the car accident, going for the run when I was already going to have the heart attack. I look at the car accident as potentially being a catalyst that accelerates the inevitable. Hence why I think we're struggling to see cause and effect with our data. So my question with whiplash is, do the people who inherently do badly and have a protracted case have an underlying weakness because of poor posture prior to the actual event? And you know, you only have to sit in the car and look across at the people driving beside you, and so many of them sit with the steering wheel with their head in a protracted position. Now you get hit from behind, the head will go forwards and you've got nowhere to go but ouch. So I would love to be able to screen people before they have a car accident to see how weak they are, and then see whether that it correlates with how well they go afterwards. And I've sort of got a bit off track. The reason I'm talking about strength in relation to your question, Dom, is that I cheat. We've got a multi-cervical rehabilitation unit that is a force transducer that actually measures neck strength. So it's very easy for us to look at neck strength in all planes of motion to determine whether or not somebody actually has an issue. We can compare it to normative data and see if they've got problems in multiple functional planes, and then using a weight stack that's connected to the machine, we can strengthen them again, just like a gym program. In terms of trying to do it without the machine, I don't like a lot of the options that are available to people, because the self-assisted stretching, well, you're already using the shoulder muscles, that a lot of which insert into the cervical spine to stabilize the head. If you're lying down, you're horizontal to gravity, and that's the most, or the heaviest position that the head can be in. Any lever horizontal to gravity is at its heaviest. So doing, you know, okay, if you're supported and you're doing chin tucks on the pillow, that's fine. But the next step is, if you try and lift your head up, well, you've just gone from the top of the weight stack to the pin in the bottom of the weight stack in one fell swoop. So I think it's a bit too much. So I think strengthening the neck muscles is one of the more difficult things to do, because also we can't change the mass of the head. That's kind of stuck. With everything else, we can say lift a weight and we can change the mass of the head. And it is rather tricky to do it in the functional position, which is again where I like the MCU, because you can do it in the functional position of being upright. Don't know if that answers your question, but
no, yeah, no, it does. I suppose. I mean, on that, I think I'm just looking at the time here, so we're on half past, so we're gonna have to wrap up for now. But for those who are interested in the multi-cervical unit and the MCU and looking at a more objective, controlled way of managing neck pain and rehabbing neck pain, we do have an upcoming webinar in the next couple of weeks. We will send that out in the follow-up email along with this recording. I certainly know I'll be watching this recording back again, because there's lots of great information. I know I adjusted my posture about 6 times, I think, during that. So yeah, following this, there will be a survey that will be sent out with some feedback. So please send your feedback. It takes about 2 minutes to do. And any advice going forward would be fantastic. If you are interested in learning any more information about LymphaTouch, MCU, or anything else that we do at PhysiQuip, then please feel free to reach out as well. All our contact information will be in that follow-up information. Otherwise, Natalie, thank you so much for joining us and presenting that. It's now your evening, isn't it? So you can put your feet up and relax for the rest of the evening. So yeah, thank you very much, and we'll sign off for now.
Pleasure. Bye.
Thanks. Bye, everybody.